I'm going to toll the bell thrice. Warning, warning, warning. What I'm about to say is controversial, and some of you are going to get upset by it. Some of you won't even believe it, and that's fair enough. But all of you should make your own minds up independently. This is my take on the story. Now, I've had a brief experience of using SSRIs, that's selective serotonin reuptake inhibitors, a treatment for depression. And that experience was short and unpleasant. A brief time on Seroxat when I was diagnosed for depression I'm pretty sure I didn't have. All I know was that for me it was nasty stuff. It was like having a bee constantly buzzing in my brain, and as soon as I could take myself off it, I did, in small doses. Now, I'm not a doctor, obviously I've got a PhD and all that. I'm a historian. And if what you hear distresses you, you must seek medical advice. You've got to do your own research, and do not be driven by what you're about to hear. I'm not the oracle. Those of you taking SSRIs, like fluoxetine, also known as Prozac, should keep at it. Apart from anything else, giving them up without reducing the dose is really dangerous. In fact, if they were an illegal drug, they'd be called addictive, which is a very big bone of contention. But I can't avoid socking you with the story as it currently stands, because it speaks to 200 years or more of psychiatric treatment. A few years back, sometime around the late 70s or early 80s, a thesis developed about what caused depression, a depletion of the neurotransmitter serotonin in the brain, because too much of it was being taken up by the presynaptic nerve after firing. If you don't understand what I'm on about, here's a short clip to give you the lowdown on neurotransmitters.
Welcome to 2-Minute Neuroscience, where I simplistically explain neuroscience topics in 2 minutes or less. In this installment, I will discuss synaptic transmission. Most communication between neurons occurs at a specialized structure called a synapse. A synapse is an area where two neurons come close enough to one another that they are able to pass chemical signals from one cell to another. The neurons are not actually connected, but are separated by a microscopically small space called the synaptic cleft. The cleft is less than 40 nanometers wide. By comparison, a human hair is about 75,000 nanometers wide. The neuron where the signal is initiated is called the presynaptic neuron, while the neuron that receives the signal is called the postsynaptic neuron. In the presynaptic neuron, there are chemical signals called neurotransmitters that are packaged into small sacs called vesicles. Each vesicle can contain thousands of neurotransmitter molecules. When the presynaptic neuron is excited by an electrical signal called an action potential, this causes the vesicles to fuse with the presynaptic membrane and release their contents into the synaptic cleft. Once they are in the synaptic cleft, neurotransmitters interact with receptors on the postsynaptic membrane. They bind to these receptors and can cause an action to occur in the postsynaptic cell as a result. This action may involve increasing the likelihood that the postsynaptic cell will become activated and fire an action potential, or decreasing it. Eventually, the neurotransmitter molecules must be cleared from the synaptic cleft. Some of them will simply drift away in a process called diffusion. In some cases, the neurotransmitter is taken back up into the presynaptic neuron in a process called reuptake. Once back inside the presynaptic neuron, the neurotransmitter can be recycled and reused. In other cases, enzymes break down the neurotransmitter within the synaptic cleft. Then the component parts of the neurotransmitter can be sent back into the presynaptic neuron to make more neurotransmitter.
The serotonin thesis has had a huge impact upon not only the way that depression has been treated, but also about how the causes of depression have been constructed by biological psychiatry. Like all ideas, the thesis has a history, which I'm going to look at very briefly. Over the last 50 years, various neurotransmitters have been implicated in depression, including dopamine, which I'm going to put to one side because it became the major suspect for causing schizophrenia, at least for a short while. We'll be dealing with that much later on. The two neurotransmitters that we're looking at here are of the monoamine oxidase class, norepinephrine and serotonin in particular. Now, during the late 50s and early 60s, there was a theory that too many of these mayos, as they are called, were being oxidized, creating a deficiency and therefore depression. A class of drug was developed to boost the mayos in the brain. They had, it has to be said, rather nasty side effects, but they appeared to work. They appeared to mitigate the depression. But drug companies are always looking for new drugs, particularly if they can replace old drugs with bad side effects. As it happened, a new thesis emerged that suggested that if too much serotonin was taken back up by the presynaptic nerve, this could lead to a dangerous depletion in the synapse, resulting in depression. The aim then became to stop the reuptake of serotonin and to increase its levels in the brain in this particular way, and therefore to prevent the symptoms of depression by preventing the depletion of serotonin. And so a new class of drugs emerged that aimed to do exactly that. And in trials and then in treatment, they appeared to work. And, this is the critical thing, because they worked, the serotonin thesis of depression was demonstrated to be true.
Note to self, be erect by 10:30. Be strong, be proud, be able, be charmed, be extended.
On the face of it, SSRIs like Prozac were incredibly successful, so much so that people started writing books like Prozac Nation. The whole world seemed to be on the stuff. And continuing trials indicated that it worked very well, especially when it was compared to placebos. Now, to be sure, it was well known that the best way was combination therapy, using cognitive behaviour therapy and drugs in tandem. That had RCTD'd best. But in the late 1990s and early 2000s, some more research was done. The principal mover behind this was an American who'd worked in both the UK and the USA, where Prozac had been incredibly popular. He was, as you will hear, especially interested in the placebo effect and how it related to psychiatric therapy. Ladies and gentlemen, men and women of minds of madness, I give you Irving Kirsch.
Early in February, actually, in 2008, an analysis of antidepressant medications that I did with some colleagues was published in the medical journal PLOS Medicine. I woke up that morning to find that our study had become the lead front page news in virtually all of the UK daily newspapers. 2 years later, it was still making news, a 4-page cover story in Newsweek. And 2 years after that, this came on television.
The medical community is at war, battling over the scientific research and writings of a psychologist named Irving Kirsch. The fight is about antidepressants and Kirsch's questioning of whether they work.
Somehow, I had been transformed from a mild-mannered university professor into a media-hyped superhero or supervillain, depending on whom you asked. So how did this all come about? And to tell you that story, I have to go back to 1998, where an earlier study of mine was published on antidepressant medication. And what I need to preface that with is the fact that when I began this study with my graduate student, Guy Saperstein, I really had no interest in antidepressants. I was seeing clients as a therapist. Sometimes they were depressed, and sometimes when they were very depressed, I referred them to psychiatric colleagues to get prescriptions of antidepressants. I assumed they worked. Everyone knew they worked. I did too. But I was interested in the placebo effect. I've always been interested in the placebo effect. And I wondered, what was the placebo effect like in the treatment of depression?
Kirsch and his compatriots decided to test SSRIs in new clinical trials where the participants in the control group were given an active placebo rather than a sugar pill. The reasoning went that many people who went on the trials had already experienced what it was like to take an antidepressant. They knew these drugs had side effects, like on the taste buds. The patient taking, say, Seroxac would experience a metallic taste in their mouth when eating. This meant that if you were on a trial, had previously taken an SSRI as a patient, but were then given the placebo, you'd have a clear idea it was the placebo because the obvious side effects were missing. Makes a monkey out of the idea of a blind trial. Sorry, monkeys. So, Kirsch asks what would happen if you replaced the inert placebo with an active one that mimicked some of the side effects of SSRIs, something like atropine. Well, what happened was this. Both the SSRI and the active placebo had demonstrably beneficial effects upon clinical depression, and the difference between the two was not statistically significant. In other words, the active placebo performed as well as the SSRI. The active placebos couldn't have had an effect on the serotonin levels of the trial participants. And just to be clear, SSRIs perform considerably better when compared to an inactive placebo or no treatment at all. So what conclusions can we draw from Kirsch's research? We can see here what conclusion he drew from it, but I'll leave you to think about it and come back to me in the forthcoming and later workshops. But as a famous philosopher, or actually I think it was a newspaper columnist once said, makes you think, doesn't it? That was a long but important journey to take in introducing much of the next two lectures and a lot of what follows them. If you didn't think that you were engaged in a subject that was really important, you should now change your mind. Just how important will be seen as we truck on. But for now, let's just review the chain of reasoning that occurred with the serotonin thesis, mapping it back to our earlier model of the therapeutic gap. It is this speculation that lies at the heart of many of the issues we will encounter in the rest of our journey and helps us to understand some of the horrific treatments that were developed and used on the back of this type of reasoning. The rest of this lecture will be firmly focused upon issues of causation, while the next will look at the therapies that were deployed in the 20th century to combat mental illness. So now we move to the psychosomatic from about 1700 to say 1900.